Hello students, this is now our content for the third exam, and from this presentation onwards whatever I post will be for the third exam, and then I will post a comprehensive presentation for the final exam. Now as I was saying in class, the peripheral artery disease is actually one category of vascular disease, peripheral vascular disease. Peripheral vascular disease means diseases of something to do with arteries and veins. So the problem can be in the artery and the problem can be in the veins. And this, when it says peripheral, that means it has nothing to do with heart or brain. It's all in the periphery, in the extremities. So we will now discuss a category of peripheral vascular disease known as peripheral artery disease. And when we say artery, think in your mind the blood circulation. Okay, so let's go to the next slide. Now, whatever I cover in this presentation plus whatever is on this slide will be the content for your chapter 38. Okay, these are some of the things which I would like you to highlight in your book and read in preparation for your third exam. Now, there is a chart on page 786, and it tells you how does the chronic peripheral arterial disease progresses and what are their stages, and you have to read this. Then there is a chart on page 788, and it shows you what is the difference between the arterial, no, what is the appearance, and also treatment of the arterial, venous, and diabetic ulcers. It's very important to know this difference. Why? Because the nurses are responsible for doing their assessment. Uh, Once I had a student who thought diabetic ulcers as a decubitus ulcer, like a pressure ulcer. You all know pressure ulcers are on prominent bony places, isn't it? Bony prominences. And diabetic ulcer is not on bony prominences. It can happen, but not necessarily. So you need to understand the difference between a diabetic ulcer or, you know, in arterial venous ulcers. So know this table. Um, there is something on page 791 and 792 which is about acute peripheral arterial occlusion. Now, peripheral arterial disease can be chronic or acute. Chronic, as you know, will be slow. Acute will come maybe in sudden form and it will present with some symptoms. And mostly there are something called 6 P's of this which you will see in books. So make sure you read this. And then there is something called Burgers and Raynaud's phenomena on page 797 and 798. And when I'm in class, I will give you some um, information specifically about the nursing responsibilities associated with these two diseases. But I want you to read what is in your EG book about these two diseases too. Then there is something called food and I said drugs. It's not drugs, it's drugs. So I missed the D over here. Food and drugs interfering with coumadin. And there's a very good chart. And let me tell you, coumadin is also one of the favorite topics of NCLEX. And they will test you on the foods which can interfere with the coumadin therapy for patients. Okay, next go to the next slide. So definition of peripheral arterial disease. Peripheral arterial disease is strongly related to other types of cardiovascular diseases and their risk factors. Patients with PAD or PAD will have high risk of mortality and other coronary events. And PAD means it's kind of a highlighting point or a marker of advanced systemic atherosclerosis. And atherosclerosis is the leading cause in majority of PAD cases, which is peripheral arterial disease. Um, this involves progressive narrowing and degeneration of arteries of upper and lower extremities. So with time, there is not oxygen going to these arteries and they are getting damaged. So this is what is happening in the peripheral arterial disease. Common sites of these atherosclerotic lesions, and they are shown in yellow here, um, in the abdominal aorta and lower extremities. So the common site of the atherosclerotic lesions can be all these yellow areas which are marked on these arteries. Atherosclerosis more commonly affects certain segments of the arterial tree. So you can see how these plaques, they can deposit in your arteries and with time can uh, compromise the blood circulation in the arteries. The pad typically appears at the ages in 60s to 80s. In the risk for this increases with age, and the patient can be in the beginning stages very asymptomatic. But when, so maybe they're like, it might happen in 40s or 50s, and then patient can show no symptoms, and then it can go, and when they enter their 60th year of their life or 60th decade or 80th decade, and they start showing some symptoms. In persons with diabetes mellitus, PAD occurs much earlier. So about 6% of adults age 40 years and older and 13% of adults age 60 years and older will have PAD. PAD is prevalence both in men and women, and it is higher in African Americans than Hispanics. Um, and mostly it remains largely undiagnosed in earlier stages. The risk factors, as we know, in most of the other coronary, uh, you know, coronary artery diseases, it's cigarette smoking. Because what happens, nicotine, it's a vasoconstrictor, and tobacco smoke impairs the transport and cellular use of oxygen. It increases the blood thickness or blood viscosity and also increases the homocysteine levels. And we just did that cover in the last content, how the elevated homocysteine levels will also lead to the arterial disease. Now, hypertension, high cholesterol, high lipids, hypertension, they also contribute to the peripheral arterial diseases. And it can affect all these arteries. So, iliac, femoral, popliteal, tibial, peroneal artery is actually a fibular artery. And the common site mostly is femoral popliteal area, which is a very common site. And why it's common site? Because it is the most common site uh, in patients who do not have diabetes. So the patients with diabetes, they tend to develop pad in the arteries below the knees. So if the patient who do not have diabetes, the most common site for peripheral artery disease will be femoral popliteal area. So it can happen in both femoral artery or popliteal artery. But if patient has uh, diabetes, then it tends to develop the pad in the arteries below the knee. In advanced peripheral artery disease, multiple levels of occlusions or blockages can be seen. So we can also understand this disease by taking this example. This is a guy, BD, and he's a 62-year-old man. He complains of pain in his lower legs when he's walking his dog. His pain is relieved with rest. He has a history of hypertension and hyperlipidemia, and he smokes 1 pack of cigarettes per day. What risk factors does this patient have? And we just covered it. He is 62, so he's in his 60th. Um, just a moment. He is in his 62 years old, so in 60th decade. So that's one of the risk factor. Then he has hypertension, and then he has hyperlipidemia, and also he smokes. So what symptom he is exhibiting? What he is exhibiting is called as intermittent claudication. Claudication is, in simple terms, pain in his legs or leg cramps. And they are intermittent because when he walks, his arteries in the legs, they um, make what do you know as a they go through anaerobic metabolism, and they produce the lactic acid builds up, and the tissues, the arteries, they become hypoxic and become acidotic, and they lead to pain. So that lactic acid buildup leads to pain, and he he has to stop. When he stops and stops walking, this pain goes away. So that's why intermittent, on and off. So he walks, he gets pain, he stops, he doesn't have his relief with rest. Um, so he is actually developing a symptom of intermittent claudication here. What other symptoms you think you might need to assess in this patient? So let's go to another side. Classic symptoms of PAD, as I said earlier, is a intermittent pain. Sorry, intermittent claudication, intermittent pain in due to a buildup of lactic acid. So this is an ischemic pain as a result of the buildup of lactic acid resulting from anaerobic metabolism. Usually in a muscle, in normal circumstances, we are having aerobic metabolism. Aerobic metabolism, where we are utilizing the oxygen to perfuse the tissues. Here there is no oxygen, the less oxygen, and in the absence of oxygen, the lactic acid builds up. And that buildup of lactic acid when he's walking, when the guy was walking, it caused him pain. And once the patient um, the ischemic muscle pain is caused by a constant level of exercise. So once the patient stops exercising, and here we saw it was walking, the lactic acid is cleared and the pain subsides. It resolves within 10 minutes or less with rest. Pad of the iliac arteries produces claudication in the buttocks and thighs, whereas calf claudication indicates femoral or popliteal artery involvement, and it is reproducible, so the pain can come and go. Now, as I was saying, this will, the if pain starts, the intermittent claudication pain starts, it will resolve within 10 minutes. And while assessing, a nurse assesses, or if you're assessing, and if you see if you think the pain is in the buttocks and thighs, then the affected area will be the iliac artery. If the pain is in calf, then it will indicate femoral or popliteal artery involvement. So now another symptom of clinical manifestation is paresthesia. Paresthesia, it's numbness or tingling in the toes of feet. It produces loss of pressure and deep pain sensations. Injuries often go unnoticed by these patients. And paresthesia results from nerve tissue ischemia. So there is no oxygen going to the body tissues which are being supplied by the arteries. And if there is a nerve tissue ischemia, nerve tissue ischemia, it can lead to paresthesia. And this is true. Peripheral neuropathy occurs more often in patients with diabetes and those who have long-standing ischemias in their leg. Neuropathy produces severe shooting or burning pain in the extremity. So, gradual reduced blood flow to neurons produces loss of both pressure and deep pain sensations. Thus, patient may not notice lower extremity injuries. So when there is low blood flow to neurons which are in the nerves, they produce loss of pressure within the tissue, and the deep pain sensations are not felt. So the injuries often go unnoticed by these kind of patients if they have paresthesia. Then you have something called thin, shiny, and taut skin. There is loss of hair on the lower legs. There is diminished or absent pedal, popliteal, or femoral pulses. There is pallor of foot with leg elevation, and then there is reactive hyperemia of foot with dependent position. So pallor is blanching of the foot. It develops in response to leg elevation, or it also called elevation pallor. So when the patients elevates their leg, you can see their leg becoming little white. Why white? Because there's not oxygen going there. And reactive hyperemia, it's redness of the foot. It develops when the leg is in dependent position. So when you lower the leg, then there is redness of the foot. So blanching of the foot or pallor is white color, and reactive hyperemia is redness of the foot, and it develops when the extremity is in a dependent position, dependent rumor. So it happens then. Okay. Pain at rest. Patients often try to achieve pain relief by dangling the leg over the side of the bed or sleeping in a chair to allow gravity to maximize blood flow. Now, pain at rest, it occurs in the foot or toes. It's aggravated by limb elevation. So, if you have pain at rest in peripheral arterial disease, you would tell the patient, don't elevate your legs. Dangle your legs. And this is a very common question in NCLEX. So you have a patient with peripheral artery disease and he's having pain at rest. What will you tell him? So you will tell him to elevate his legs. We will tell him to dangle his legs. not elevate, because elevating the legs will aggravate his problems. And it occurs from insufficient blood flow, and it occurs more often at night. Mm, okay. When assessing BD, you find that his feet are pale and cool to touch. He has diminished pedal and posterior tibial pulses and decreased sensation. He has a small open area on the lateral side of his left ankle. Now, what are your concerns regarding this findings in BD? Now, if you assess all these signs and symptoms, they are consistent with the lower arterial circulation. And there is also evidence of complication of arterial ulcer, the small open area. So let's go to the next slide. Complications, there is atrophy of the skin and underlying muscles. The complications, now when I'm saying complications, that means when somebody has developed peripheral arterial disease, what are the complications he can go through? He can go through atrophy of the skin and underlying muscles. If there is a wound, or there is any injury, there'll be a delay in healing. There can be a wound infection. There can be tissue necrosis. Necrosis, what? Dead tissue. Dead tissues. There can be arterial ulcers. So all this can be the complications related with peripheral arterial disease. Now, non-healing arterial ulcers and gangrenes are most serious complications, and it may result in amputation if adequate blood flow is not restored, if severe infection occurs. And I think during your rotations in all these 4 semesters, you must have seen a patient with amputated, below knee amputation because of the complication of having of ulcer or gangrene. Um, if PAD is presented for an extended period of time, uh, then collateral circulation can happen. And if the collateral circulation can happen, it may prevent gangrene of that extremity. Um, so when collateral circulation is also not possible, then the patient's tissues, they die completely, and the body is not used, that part of the body is not useful, and then there is amputation. Uncontrolled pain and severe spreading infection are indicators that an amputation is needed in individuals who are not candidates for a treatment called revascularization. So patient is asking for more and more pain medicine, and his pain is not getting reduced, and then his infection is spreading, antibiotics are not effective, and then the doctor says it's better if we cut this part of the limb. So, and also even the other kind of surgery or anything also will not be helpful. So there is something called Doppler ultrasound diagnostic studies, Doppler ultrasound, ankle brachial index, angiography, and magnetic resonance angiography, and then duplex imaging. Now, when palpation of a peripheral pulse is difficult because of severe peripheral arterial disease, the Doppler can determine the degree of blood flow in that artery. A palpable pulse and a Doppler pulse are not um, equivalent, and the terms are not interchangeable. So a pulse which you palpate and a pulse which is known from a Doppler are not equal. So don't try to interchange these two words. Um, Doppler will determine the degree of blood flow in the artery. there is something called segmental blood pressure. So if I don't know why there is a small thing written owner 52113 aging. I don't know why it came from where, or maybe it came from one of my slides on this. So just ignore this small thing which is written here, owner 521, something like that. Okay. Uh, Now, a drop in segmental blood pressure of greater than 30 millimeters of mercury suggests peripheral arterial disease. So, with segmental blood pressure, you have used Doppler ultrasound and you have seen the segmental blood pressure. And if there is a drop of greater than 30 millimeters of mercury, it will suggest peripheral arterial disease. Then ankle brachial index, it is calculated by dividing the systolic blood pressure at your ankle. So it is divided by the systolic blood pressure of the ankle by the systolic blood pressure at the brachial artery. So, and when you have brachial, then you will think which one, right or left. So usually it's the higher one of both. See if it's ankle or brachial systolic pressure, there are two. We have brachia in two places, and then we have two ankles. So whichever is the higher systolic blood pressure, when you take blood pressure on these two spots, then you divide them. Then that is what is your ankle brachial index. A normal ankle brachial index is 0.91 to 1.30, and it indicates adequate blood pressure in the extremities. An ankle brachial index between 0.71 and 0.90 indicates mild peripheral arterial disease, and between 0.41 and 0.70 indicates moderate peripheral arterial disease, and less than 0.40 indicates severe peripheral arterial disease. So the ankle brachial index, which is done using a handheld Doppler, and there is a way of doing it, and then based on its numbers, it can tell you the severity of the peripheral arterial disease from mild to the severe. Um, Angiography and magnetic resonance angiography, they will delineate the location and the extent of pad. So they'll show you where exactly the occlusion of the blockage is and how far it has gone. So it'll take a picture, it'll take an image. So let's go to the next slide. Now with VD, the angiography was done and they saw some completely obstructed vessels in BD's lower extremities. He was diagnosed with peripheral arterial disease. And so what treatment this BD can have? So most important thing which he can do is tobacco cessation, so stop smoking. Uh, Now because there is a high risk, and as I said in the beginning, no, did I say in the beginning? Because the peripheral arterial disease has a deep relation with the cardiovascular disease. So because of the high risk for MI, ischemic stroke, and also CVD related deaths, the first treatment goal is to aggressively modify the cardiovascular risk factors in all patients with peripheral arterial disease. So the peripheral arterial disease and the cardiovascular disease are deeply related. So if the peripheral arterial disease has a risk factor which is also for the CVD or the cardiovascular disease, they want these to be, um, they want Their treatment goal is to aggressively modify the CVD risk factors in all patients with PAD. So, and the most notorious risk factor is tobacco cessation. So that's very important. Um, and then also the current guidelines for management of peripheral arterial disease recommends its aggressively lipid management for all PAD patients with the goals like their LDL should be less than 100 milligram per DL, their triglycerides should be less than 150 mg per DL, and their high density lipoproteins HDL should be greater than 40 milligram per DL. And this is something I just tested you on your last exam. To manage lipids, both dietary interventions and drug therapy will be needed. Statins, example Zocor, which is also known as simvastatin, it lowers LDL and triglycerides levels and it reduces cardiovascular disease, morbidity, and mortality risks. In PAD, patients with any coexisting diabetes or renal efficiency, we want the blood pressure to be maintained with less than 130 over 80. So if PAD patients and they have also something diabetes or any renal diseases, we want their blood pressure to be at least less than 130 over 80. And now diabetes is a well-known risk factor for PAD and it increases the risk of amputation more in these patients. And I have witnessed uh, leg amputation in OR, and believe me, it's very gross because it's we know that when you give education to patients, especially diabetic patients, to manage their diabetes, and when they are non-compliant or maybe they have not do not have any support system, and it comes down to this that they have to lose their half of their leg maybe. So it's recommended that diabetic patients maintain a glycosylated hemoglobin, which is hemoglobin A1C below 7, and and at least as near as possible to 6. Okay, and less than the hemoglobin A1C should be less than 7. Remember that. That's the normal for but for diabetes they say if it's not 7 at least till 6. Drug therapy, ACE inhibitors, ACE inhibitors, which is angiotensin converting enzymes inhibitors. What angiotensin is a hormone and it is a vasoconstrictor. So the drugs which are known as ACE inhibitors, they actually inhibit, they stop the angiotensin activity that is of vasoconstriction and thereby raising the blood pressure. So these ACE inhibitors will help in peripheral arterial disease. And this is ramipril. It lowers the cardiovascular morbidity, it lowers mortality, it increases the high peripheral blood flow, it increases the ankle brachial index, and it also increases the patient's walking distance. Antiplatelet agents, aspirin and Plavix can be used, and the guidelines for oral antiplatelet therapy recommends aspirin daily from 75 to 100 milligram for patients with asymptomatic peripheral artery disease. And they say that it's helpful. Aspirin intolerant patients who cannot tolerate aspirin may take Plavix. Now, now there is a drug alert on Plavix. It says when uh, there is a drug alert on Plavix, like Plavix and omeprazole, which is popularly known as Prilosec. So it is said that antiplatelet effect of Plavix is reduced by about half when you give patients Prilosec, when it's given with Prilosec, and this increases the risk of MI and stroke. So don't try to mix Plavix and Prilosec. Okay? So don't try to mix Plavix and Prilosec. Let's go to the next slide. We will continue with the drug therapy and the drugs prescribed for treatment of intermittent claudication. Now, um, I have witnessed patients who have gone through the intermittent claudication, and believe me, their pain is unbearable to them. Their pain is very, it's painful. And then the drug which is prescribed is Platel and Trental. So they both end with tal. And the Platel it's um, is recommended as first line drug therapy for patients with intermittent claudications who do not respond to any exercise therapy and are not candidates for any surgical interventions. So, Plato is recommended as first-line drug therapy for patients with intermittent claudication who do not respond to exercise therapy and are not candidates for surgical or radiologic interventions. Um, and what does it do? It inhibits the platelets aggregation and it also increases the vasodilation. So by increasing the way the vasodilation, it promotes blood flow through those arteries. The Trental, it has high erythrocyte flexibility and it decreases the thickness of the blood. They were promoting the blood flow through the vessels. Let's go to the next slide. Now the patient we were following, BD is ordered the following drugs: aspirin 81 milligram daily, Zocor 10 milligram, HS. I hope you all know what HS is, because once we had a pharmacology exam and we gave them some abbreviations and the student put HS as high school. So I hope you know what HS is. Ramipril 2.5 milligram daily, and then Trental 400 milligram TID. Um, I would ask you to at least go through these medicines in your book, um, and then uh, you also consider the nursing consideration for aspirin, Zocor, Ramipril, and Trental. So I want you to research from the book about these medicines, the nursing considerations for all these four drugs. Okay, next go to the next slide. Exercise therapy. Exercise improves oxygen extraction in the legs and skeletal metabolism. Walking is the most effective exercise for individuals with claudications. So 30 to 60 minutes daily and 3 times a week. So a supervised if it is a supervised peripheral arterial disease rehab program, it is an effective means of improving exercise performance. Um, so there is a rehab program for these patients who are suffering with intermittent claudication. It's not that, because it gives you pain, don't walk. No, they are supposed to walk, and they'll walk 30 to 60 minutes daily, 3 times a week. Um, and they can also do some sort of supervised treadmill exercises. So by doing these exercises, they will improve the uh, oxygen extraction in the lungs and also the aerobic metabolism. Um, Nutritional therapy, their BMI should be less than 25. Um, Waist circumference less than 40 inches for men and less than 35 inches for women. Mm, it's a difficult job, less than 35 inches for women, but never mind. Diet high in fruits, vegetables, and whole grains, and low in cholesterol, saturated fat, and salt. Patients taking antiplatelet agents so patients who are taking any antiplatelet agents, NSAIDs, and anticoagulants, example warfarin, should talk to their doctor before taking any dietary or herbal supplements due to potential interactions and bleeding risks. So if somebody is taking over the counter some herbal supplements or any dietary thing, any dietary changes for this, they should talk to their doctor uh, before having it, and also if there are any NSAIDs or antiplatelets or any anticoagulants, they should talk to their doctor. Now, critical limb ischemia is a condition characterized by chronic ischemic rest pain lasting longer than 2 weeks. It can happen in arterial leg ulcers, or it can lead to gangrene of the leg, which has been due to peripheral arterial disease. So critical limb ischemia, it explains you in itself what it is. Chronic, and the highlighting point is the rest pain, which is lasting longer than 2 weeks. There is a bypass surgery where the revascularization is done. Now, the percutaneous translumen angioplasty is recommended in patients with a life expectancy of less than or equal to 2 years. Um, Spinal cord stimulation may be helpful in managing pain and preventing amputation in patients with critical limb ischemia. Other promoting strategies include gene therapy and other cell therapy to stimulate the blood vessel growth. Um, we if somebody has critical limb ischemia, how we can help? We will make sure that the leg is protected from ischemia. Protected from trauma. There is low ischemic pain, the no infection, improve the arterial perfusion, and then the other strategies is spinal cord stimulation and angiogenesis, which is cell therapy to stimulate blood vessel growth. BD returns for follow-up in 3 months. His BP and lipid levels are stabilizing, but he complains of increasing leg pain at rest. Um, his doctor says it is time for him to consider an intervention to improve his circulation. So, what are his options BD has at this point? Um, we can do interventional radiology procedures, and interventional radiology procedures are indicated when when intermittent claudication symptoms are making the patient incapacitating, like is interfering a lot with his ADLs, and there is pain at rest, and there is so much ulceration or gangrene in the limb or in the extremity that you know that there is a risk of losing the limb at all completely. And this procedure, the interventional radiology procedure, will take place in a cath lab, and what interventions will be used, it depends on the kind of blockage and its location, along with it the severity it's presenting. uh, the pre-procedural and the post-procedural nursing care, so the before care and after care for the interventional radiology procedures is the same as for a diagnostic angiography procedure. Antiplatelet agents are necessary after the procedure to reduce the uh, risk of restenosis, like uh, blood vessels becoming blocked again. So after this procedure, antiplatelet agents are given to reduce the risk of restenosis. long-term low-dose aspirin therapy is recommended as a post-procedure. Okay. We did deal with this. We dealt with this in the last content, and it involves the insertion of a catheter through the femoral artery. It contains a cylindrical balloon. Balloon is inflated, dilating the vessel by compressing atherosclerotic intimal lining, and stent at the mesh is placed. And stents are expandable metallic devices. They are positioned within the artery immediately after the balloon angioplasty is done. The stents acts as a scaffold to keep the artery open. There is something called atherectomy, so it is removal of the obstructive plaque. So that the atheroma, you remove the atheroma. So that is the obstructive plaque. It's performed using a cutting disc, laser, or diamond tip. Let's go to the next slide. Cryoplasty is the specialized balloon is filled with liquid nitrous oxide that changes from liquid to gas as it enters the balloon. And the expansion of this gas results in cooling to 14 degrees Fahrenheit. Now the cold limits restenosis by reducing smooth muscle cell activity. So it combines percutaneous transluminal angioplasty and cold therapy, and liquid nitrous oxide is used. So cryoplasty is a process in which liquid nitrous oxide is used, and it changes from liquid to gas as it enters the angioplasty balloon, and the expansion of the gas results in cooling in that atmosphere where the balloon is to 14 degrees Fahrenheit, which is minus 10 degrees centigrade. And the cold, it limits the restenosis or the blockage. It limits the reblockage of the artery by reducing smooth muscle cell activity. So the cold is reducing the inflammation response and thereby preserve uh, preserving the high functional level of that artery. Most common surgical approach is peripheral arterial bypass surgery with autogenous vein or synthetic graft to bypass blood around the lesion. PTA with stenting may also be used in combination with bypass surgery. Now, surgery is all indicated in patients with long areas of stenosis or severely calcified arteries. Synthetic grafts typically are used for long bypasses, and when a person's own vein is not available, human umbilical vein or any other synthetic graft is an alternative. Okay. If you see the diagram A, there is a femoral popliteal bypass graft around an occluded superficial femoral artery. And in diagram B as in baby, there is a femoral posterior tibial bypass graft around occluded superficial femoral popliteal and proximal tibial arteries. So there is a bypass graft. You can see that, the blue. It all shows you that how the graft has been made. Now there is surgical therapy, endarterectomy, patch graft, angioplasty, and amputation. Don't get uh, kind of anxious, excited by this big word endarterectomy. No, there's nothing. It involves just opening the artery and removing the obstructing plaque. So they open the artery and they remove the blockage. Patch graft angioplasty is opening the artery, removing the plaque, and sewing a patch to the opening to widen the lumen. So the patch graft angioplasty is they will open the artery, they will remove the plaque. So if they open the artery and remove the plaque, that's called endarterectomy. But if along with opening the artery and removing the plaque, they sew a patch to the opening of the artery to widen the lumen, then it's called patch graft angioplasty. Amputation may be required if tissue damage is so much that the gangrene has developed and then all major arteries in the limbs are getting blocked. So that's why. Nursing management, you need to know about their history, diabetes, smoking, hypertension, hyperlipidemia, obesity. Nursing assessment, you will see if the patient, how far patient can walk, exercise, and then any loss of hair on legs and feet, decreased or absent peripheral pulses. BD then undergoes bilateral PTA with stenting. Then what nursing diagnosis can be appropriate for him after going through this procedure? Think about this. Okay, what goals would you develop for him post-op? So it will be no different from somebody who's going through the procedures of angiography. Nursing diagnosis, ineffective tissue perfusion. That's I think the major one. That's why this disease happened. Impaired skin integrity, activity intolerance, ineffective self-health management, or being non-compliant with whatever we are teaching them. Overall goals for patient with PAD: adequate tissue perfusion, relief of pain, increased exercise tolerance, and intact healthy skin on extremities. And do you think it can be done? Yes, it can be done if they have a good nursing doctor team and if the patient is also motivated to do good for himself. Nursing implementation, health promotion, identification that who's at risk, then how they can modify their diet, how they can take care of their feet, and then avoidance of injuries. BD comes to the recovery area after PTA with stenting and he has bilateral dressing on his groins. He is positioned supine. And yes, we had an argument about supine or elevation. So you can do supine or head of the bed elevated. I would have no problem with that. So this BD was positioned supine. So what can be a priority for assessment when he comes back after this stenting done, and how will you proceed with the ongoing care during his recovery? Um, Acute intervention, frequently monitor after surgery. Well, it's not only for this surgery, for any surgery. Skin color, temperature, cap refill, presence of peripheral pulses, distal to the operative side. So, and then sensation and movement of extremity. Check the operative extremity every 15 minutes in the beginning and then hourly for color, temperature, cap refill, presence of peripheral pulses, sensation, and movement. Loss of palpable pulses or change in the Doppler sound over a pulse requires immediate notification of the doctor or radiologist and prompt intervention. Okay, next go to the next slide. Oh, so we are on slide 41. I think there was a little bit of pause. Um, Acute intervention will be continued circulatory assessment, monitor for potential complication. Knee flex position should be avoided except for exercise, and turn and position frequently. Now, after the patient leaves the recovery area, you will continue to monitor perfusion to the extremities and you will assess for potential complications. And what can be the complications? Complications can be bleeding, hematoma, thrombosis, embolization, and compartment syndrome. When I say thrombosis, embolization, it also leads to two words, thrombus and emboli. I would recommend look in the medical book, terminology book, or in glossary. What is the difference between a thrombus and emboli? A dramatic increase in pain, loss of previously palpable pulses, extremity cyanosis or pallor, or decreasing ankle brachial index, numbness or tongue tingling, or a cold extremity It might suggest a blockage of the graft or stent. Discourage this patient with prolonged sitting with leg dependency as it may cause pain and edema. So, increase the risk of venous thrombosis and place uh, and there is an increased risk of venous thrombosis as if the patient has prolonged sitting with leg dependency. Um, if edema or if swelling develops, position the patient supine and elevate the leg above the heart level. Elevating the leg above the heart level will help with circulation. Walking even short distances is desirable. The use of a walker may be helpful, especially in frail elderly patients. So, BD is being discharged home. What will you teach him regarding immediate care and precautions at home, and what patient teaching is essential for him to manage his disease? Ambulatory and home care, we will manage his risk factors. So, there should be a management of risk factors. Continued tobacco use will decrease the long-term patency rates of graft and stents and will increase the risk of an MI or stroke. So patient, we put some graft and we put some stents and we're thinking the patient will be okay, but then he keep on smoking. If he keeps on smoking, it will decrease even the graft's functionality or the graft's usage. Long-term aspirin therapy is recommended for patients after surgery. Encourage physical activity and explain that improves a number of CVD risk factors including hypertension, hyperlipidemia, obesity, and glucose levels. Um, and a good foot care is very important. Ambulatory and home care. Daily inspection of the feet is important. Comfortable shoes with rounded toes and soft insoles is important, and shoes lightly laced is important. Maintain adequate peripheral tissue perfusion. The evaluation would be to maintain good perfusion tissues, increase activity tolerance and knowledge of disease and treatment. Plans for walking program, increase activity tolerance, verbalize key elements of therapeutic regimen, whether the patient is knowledgeable of the disease, whether he understands his treatment plan, whether he will reduce the risk factors, and then whether he knows about the proper ulcer and foot care. So there is a question in the end. A patient with PAD has marked peripheral neuropathy. An appropriate nursing diagnosis for the patient is what? So there are four options. Risk for injury related to decreased sensation, impaired integrity related to decreased peripheral circulation, ineffective peripheral tissue perfusion related to decreased arterial blood flow, and activity intolerance related to imbalance between oxygen supply and demand. The answer is A. Risk for injury related to decreased sensation. Peripheral neuropathy is caused by diminished perfusion to neurons and it results in loss of both pressure and deep pain sensations. The patient may not notice lower extremities injuries. Neuropathy increases susceptibility to traumatic injury and it results in delay in seeking treatment. So, yes, the other things are okay, but if they have added peripheral neuropathy, that means they're trying to tell you patient will not be able to sense if he gets hurt or injured. Okay, so this comes to the end of peripheral arterial disease presentation. Thank you.